couple of other hosts on. I do apologize if we have any breakdown in our communications. I think before we get started, we just like to thank our speaker, Dr. Zaheer Bhayat and Zaheer for sponsoring the webinar. While we're waiting for everybody to come on, some housekeeping. So I'm going to request everybody to keep their videos off unless they're speaking, and please mute your microphones. We're going to try and make this as interactive as possible. If you feel like you have urgent burning questions during Dr. Bhayat's talk, feel free to type them in the chat box, and he or myself or the admin will pick it up as we go along. If we miss out on any of the questions, then we'll try and address it later after the slideshow. While we're waiting, I thought while we're waiting for other people to log on, I thought since it's become the end of Rabiul Awwal, we can have some encouragement. You know, Rabiul Awwal is a very significant month for the Muslims because it's the month in which our Prophet was born. I attended a lecture the other day, and the Maulana there mentioned a very interesting hadith. In a time of social media and Zoom meetings where we've lost the ability to interact with each other, especially in face-to-face interactions, we find oftentimes our expressions are not good enough. We tend to not make eye contact. And he mentioned the hadith of Nabi Sallallahu Alaihi Wasallam, where Nabi Sallallahu Alaihi Wasallam says, Al-mu'minu mir'atu akhihi. Roughly translated, a Muslim is the mirror to his brother. And the three take-home points he said about this, because the talk concentrated on the soft skills of the Prophet Sallallahu Alaihi Wasallam. And I think the three talking points he reflected on, he says that a mirror, why was there a comparison to a mirror between you and your brother? And the one thing he says, it's a reflection of yourself. So depending on your mood, your feelings, your prejudices, all of that is then reflected from that brother into you. So you need to be that reflection to your brother. The one very important thing he mentioned is that the mirror has no memory. So, you know, we have this habit of remembering things and bringing them up at family functions or bringing them up at other conferences and not referring to colleagues because we have these so-called grudges. So I think a mirror does not have a memory, and that's how we should be. We should forgive and forget. And I think the other thing, especially in the social media era, in an era where we've lost the ability to communicate effectively, especially if we have differing opinions, is that the mirror does not amplify. And I think that's also crucial, because we'll get one story, add a few other tidbits, and then push it on. And we should always verify before we amplify to make sure that the information that we're putting out there is correct. Being part of the healthcare fraternity, we are all very familiar with evidence-based medicine. We are all very familiar with being able to quote sources that are reliable. In the post-COVID era, there's been lots of controversy surrounding these things. So I think we should verify before we amplify and sort of keep this in mind in all our interactions. Just in a quick recap of the soft skills that were highlighted in the talk by the Imam in the mosque, is that a Muslim is like a mirror to his brother. He should be, what he sees in it, he should reflect what he wants to see from his brother. He should not have a memory of all the wrong things that his brother has done, and he should not amplify. I think most of us are on, we've got already 80 participants. I think it's time for us to start. I'm going to introduce our speaker. Our speaker tonight is familiar to many of us. He is an endocrinologist and the head of internal medicine at the Helen Joseph Hospital. He's very intimately involved in the examinations of the both undergraduate and postgraduate training of the physicians, and also of the physicians sitting for their certificate in endocrinology, and he's also involved in the Lenasia Clinical Trial Center. I'm not going to waste too much more time going through his extensive CV. I'm just going to ask Zaheer, you can take it away. Jazakallah Zaheer.
Assalamu alaikum. Jazakallah Zaheer. I'm going to share my screen. Can everyone see my screen?
Yeah, it's projecting nicely.
All right. Jazakallah for inviting me and for giving me an opportunity to give this talk. For once, I'm going to take off the endocrine hat and just talk general in terms of physician work. And we're going to talk about cardiovascular disease, a solution-oriented approach to a fairly complex situation, and how can we simplify treatment options for our patients. So these are my disclosures. The global burden of disease is quite high, and we're going to go through that. Then we're going to look at which areas to target. Then we're going to look finally at adherence to therapy, and a few take-home messages at the end. So when we're looking at hypertension and dyslipidemia, cardiovascular disease predominates. Worldwide, it is the #1 killer, where patients across the world are exposed. And if you look at top 10 causes of death across the world, cardiovascular and atherosclerotic diseases predominate. We have about 18.6 million deaths every year from cardiovascular disease, and it accounts for 33% of all global deaths. The majority of them are taking place actually in the low and middle income countries. Now, if you look specifically at South Africa, this is from Stats SA, and if you look at the top 10 across both genders, we see that tuberculosis is still #1. Very quickly, however, we start seeing cerebrovascular disease, hypertensive disease, and ischemic heart disease starting to make its appearance. Now, clearly, there are differences between men and women within the South African context. In the South African context, diabetes is the #1 cause of death amongst females, whereas atherosclerotic combined diseases, trauma, infectious diseases feature much higher amongst males. If we break it down by ethnicity, here we're looking at Black, African, colored, white, and Indian. Across the board, we're seeing quite things that we are fairly familiar with. For example, within our Indian community, diabetes predominates, followed very quickly by ischemic heart disease. And if we just take the diabetic population, 70% roughly of patients with diabetes will have some sort of cardiovascular disease. So that just adds to the number. We are beginning to see an emergence amongst our African patients of cardiovascular disease. So if we go back 15 to 20 years, when I was definitely an intern at Baragwanath Hospital, the ICU and the cardiac ICU were usually filled with Indian and white patients. Today, it's filled with all patients, including Black African patients from the Soweto drainage area. So going back to atherosclerosis, as we mentioned, it's responsible for 50% of all the deaths in the first world, 30% of all premature deaths, and most of the deaths are actually ischemic. This equates to roughly 1 death every 1.5 seconds. So if we've been talking now for about 1.5 minutes, we're counting at least 10, maybe 15 deaths that have taken place worldwide from atherosclerosis. What contributes to atherosclerosis? Well, each of these on the screen is an independent risk factor, but we have to talk about specifically today the hypertension and the dyslipidemia part of it. Family history plays a role, and especially we keep reminding ourselves that when we take a history from patients, it's family history of a cardiovascular event at a young age. Smoking definitely is a bad contributor. The recent NHANES study says that if we can get patients' cholesterol to below 2.5 on an LDL and stop patients from smoking, we can decrease the risk, or we can decrease the number of ischemic events by up to 70%. Let's focus a bit more on hypertension and dyslipidemia. If you look at hypercholesteremia, there's 1.76 billion people worldwide living with cholesterol. Now, clearly, if you look at this map, we see the dark pink areas represent higher prevalence. There is a big problem with this map, and that is South Africa is actually very, very poorly represented. If we actually take data, done surveillance data from the University of Cape Town, as well as from Wits University, we find that 90% of all South Africans above the age of 30 will have a total cholesterol above 5. And that's one of the highest levels of cholesterol of any country worldwide. That is irrespective of race or gender. So we basically had on the one part of South Africa, the indentured laborers coming in, and the other part we had Van Riebeeck and his people coming in, and we basically populated South Africa, distributing cholesterol throughout the country. And if anybody wants to do studies in cholesterol anywhere in the world, and there's a lot of new molecules on the market, they all come to South Africa to do the research. If you look at hypertension, we have about 1.13 billion people worldwide living with hypertension. Again, we see Africa being underrepresented. I think, however, the similar data as with cholesterol in that we don't have good surveillance data for our population. We still see this on a day-to-day basis, patients coming in with acute events, you measure their blood pressure, it's 200 systolic, and you ask them, how long have you been hypertensive? And it's like, I'm not hypertensive. But actually, they've been hypertensive for a while. We just haven't had access to healthcare. One hypertensive out of two actually has dyslipidemia, regardless of where the patient. So the combination of dyslipidemia and hypertension is quite prevalent. Who are at risk for cardiovascular events? If you take all these patients, what are your risk factors? We've spoken about some of them, but a couple of these here that we actually need to highlight. A person who has had a previous event is at a 60% risk of having a secondary event. If a patient has had some sort of intervention or revascularization, again, their risk is over 60%. And this morning we presented at the university, one of the registrars, a patient with previous stent insertion, presenting very soon after that with a second event. Hypertension itself causes the risk, and patients with symptoms and hypertension are at increased risk of cardiovascular events. If you look at the effects of blood pressure and lipids on your cardiovascular risk, it is well accepted that high blood pressure is considered to be one of the leading risk factors for global cardiovascular disease. Elevated blood pressure was the leading cause of premature death, especially under the age of 50, and accounts for almost 10 million deaths and 200 million disability lives. Now, again, we tend to overlook this. People who are living with hypertension, diabetes, specifically those two conditions, they actually spend a lot of time at home on sick leave, where they should be working and they should be interacting, contributing to the economy, but they're actually on disability adjusted time, sitting at home. If you look at cholesterol, cholesterol is an important risk factor, and globally, 33% of coronary artery disease can be attributed to hypercholesteremia alone. And there's a long linear relationship between cholesterol and cardiovascular risk, that the higher the cholesterol goes, the more the increased risk that you have. This is seen especially in patients who have familial hypercholesteremia, for example, where they have their first event or their first cardiac event before the age of 20. What about cardiovascular disease in South Africa? Now, daily we have over 200 South Africans having a heart attack every single day and dying from that. So it's different from those who actually have a heart attack and survive. We have over 200 people dying from a heart attack every single day. 10 people suffer from a stroke in South Africa every single hour. Combined, that places a significant burden of disease on our population. Now that we know how important these are, what do we actually need to target? This comes from the Heart Foundation, South Africa, and they've put up this myriad of factors that we need to actually target to try and improve or decrease the risk of heart and stroke in South Africa. And we know some of them: healthy, happy lives, try and get out of the city, become less stressed, there's diabetes, alcohol, and they talk about genetic risk, etc. as well. Today, we're not going to focus on all of them. We're going to focus specifically on the hypertension and the dyslipidemia. So the goal of management is to actually break this. This is called the cardiac conundrum, and we actually want to stop this from happening. And that's our goal, to basically put the cardiologist out of business. If we look at dyslipidemia and hypertension, on the left-hand side, we see a study. This is a meta-analysis of almost 200 studies. And you're looking at 2 million participants with 20 million person years of follow-up. And in this study, they adjudicated over 150,000 cardiac events. Basically saying for every 20 millimeters of mercury, your cardiovascular mortality doubles. So that's basically putting it, if you go from a blood pressure of 120 to 140, your risk of dying from a cardiac event will double. If we look at the graph on the right, it shows that the higher the LDL risk, the higher the risk for cardiovascular disease or coronary artery disease. This is something we know quite well. And when doing this talk, the hypertension risk is actually the one that's quite scary. If your patients are sitting with blood pressures in the region of 170 to 180, they are 8 times more likely to die from a cardiac event. The 2018 guidelines came up with 4 categories of blood pressure, which we should be aware of. And this is the European Society for Cardiology and the European Society for Hypertension. The first is the patient who has above normal blood pressure. So that's a systolic between 130 and 140, and a diastolic between 85 and 90. Here, the recommendation is to initiate lifestyle changes. And then if you have a high-risk patient, such as somebody who smokes or has diabetes or very strong family history, consider treating this patient. If there is grade 1 hypertension, as shown on the screen, between 140 and 160, or a diastolic between 90 and 100, then you should start this patient immediately on drug treatment. And the little box at the bottom suggests that if within 3 months you're not getting any sort of BP control, then you need to consider dual or higher levels of therapy. If you've got grade 2 hypertension, and this is even a higher blood pressure presentation of 160 to 180, or diastolic of 100 to 110, immediately consider treatment in this patient, and you should, again, control blood pressure within 3 months. A similar thing goes for a patient who has grade 4 hypertension, or in this case, the grade 3 systolics over 180. There are some other changes, and the target recommendation is to keep blood pressure of under 140/90. If the treatment is well tolerated, you can look for a level below 130/80. Now, we need to remember that the target for blood pressure is a J curve, meaning that beyond a certain level, we cannot push the blood pressure too far down because we have an increased risk of cardiovascular events. So if you have, for example, a patient who has a systolic of 150, we're definitely not targeting a systolic of 100 or 105, because that's also going to increase your patient's risk. In a patient who is slightly older, the age above 65, we allow slightly higher blood pressure of 130 to 140. And a diastolic in all patients should be around the level of 80. Now, this is sometimes difficulty to achieve because we have a disproportionate rise in systolic blood pressure as compared to diastolic blood pressure as our patients get older. In terms of putting our patients onto therapy, what therapy should we use? Now, the ASH guidelines again come to our assistance, and they say if you're giving a single therapy dual combination, try for 1 tablet up front. You should use either an ACE or an ARB, combining with a calcium channel blocker or diuretic. Now, we know within our different population groups, different patients will respond to different drugs. And again, if they have different comorbidities, you're going to choose a different drug or different combination. For example, patients who have diabetes, who have target organ damage such as hypertension concomitant, or they have kidney disease, you're going to aim for an ACE or an ARB early on. Whereas those who have no target organ damage or have very low blood pressure, you're going to use something like indapamide, a non-thiazide-based diuretic. The step 2, if you're going to use, try a triple combination, so an ACE and an ARB with a calcium channel or diuretic. And here we do have triple combination tablets, which are available, and there are quite a few on the market. When your patient has resistant hypertension, which is defined as patients being on at least 3 drugs, plus a diuretic, and all at appropriate doses, then you can consider looking at spironolactone, alpha or beta blockers. Now, one thing for us to mention that beta blockers can be used, but you have to have specific indications for their use. For example, heart failure, angina, or atrial fibrillation. And it's not a one-step approach for everyone. This is quite intense looking. This is the lipid evaluation. But basically, the 29 guidelines, as well as the South African guidelines, come up with a very simple concept. If your patient has a low risk, you're going to aim for LDL levels about below 2.5. And as that risk increases, you want to go to around 1.8 and then 1.4. And now, even if we look at what's coming in terms of diabetes, we're probably going to introduce a lower cutoff for patients living with diabetes who actually are at high cardiovascular risk or having had previous cardiovascular events. How do we do this? Well, we use the Framingham scoring system. And Framingham, you can download these. There's multiple apps. The one that we tend to use a lot is called MedCalc. And the MedCalc, basically, it's a 4-step where you put in your patient's age, you put in their cholesterol levels, whether they're a smoker, they're non-smoker, their blood pressure, and whether they're on treatment. And it then puts out a cardiovascular risk score for you. So if your patient is at certain risk, what your target LDL should be. If they're at higher risk, what it should be. Now, we have to remember that certain patient groups are not catered for in the Framingham scoring system. For example, if your patient has had a previous event, you should always treat that. If there's strong family history of cardiac events at a younger age, or patients with diabetes. That's one of the shortcomings of the Framingham scoring system, as well as the ASCVD scoring system. But in those patients, because the risk is higher and we understand the risk, we are usually have a lower threshold to treat. Once you start adding the two together, you actually have double the trouble. Hypertension and dyslipidemia combined quadruple your risk for a cardiovascular event. And since 1 in 2 patients with hypertension have concomitant dyslipidemia, it makes sense to then consider statin therapy as first-line treatment in almost all patients with hypertension. What about elevated heart rate? Now, we have a longitudinal prospective population-based study here on the screen, which ran for 21 years. And it was for men from Sweden born in the area of the 1940s. They enrolled almost 800 patients, and they re-examined them at 10-year intervals. And the study aimed to investigate the impact of your heart rate when you were enrolled in the study on cardiovascular morbidity and cardiovascular mortality. And this is quite interesting data. And they showed that your resting heart rate above 80 or 75 beats per minute doubles your risk of a cardiac event compared to those who had a heart rate below 60. Now, we never really thought about this, and we're not saying everyone should try and decrease their heart rate to below 60, but it's just something to be aware about, that heart rate does increase, and an increased heart rate over time does contribute to cardiovascular death. It's also important for us to remember post-COVID, we are seeing a large number of patients who actually have persistent tachycardia or POTS syndrome as well, with elevated heart rates at minimal exertion or at rest. Putting all these patients onto treatment, the question is, do they actually take their treatment? So this is a study looking at adherence, and it's a retrospective study of about 8,500 patients. It was done in the US and patients at primary care level, looking at antihypertensive treatment and lipid-lowering treatment. And when you look at these patients at initiation, so when they leave your practice, they usually all have a script in hand. They're quite keen to go and fill the script and take their medication. But by 6 months, we have only 1 in 3 patients actually taking treatment. Now, we have to look at this and try and understand, why does this occur? Does it matter? Does it change because of the different drugs that they're using? Here we have a massive meta-analysis of almost 376,000 patients. They combined it from 20 different studies, and they looked at prescription refills and adherence to therapy. They broke it down between primary prevention and secondary prevention. So you want to prevent the first event on the left-hand side. And if you look at that, 1 in 2 patients, and in some cases 1 in 3, will only actually get their cardiovascular medication. We're talking about hypertensive, statins, and you're looking at antiplatelet therapy. Once they've had a cardiac event or a stroke, the chances of them taking medication then almost doubles from around 40% all the way up to 80%. The consequence of non-adherence basically says that 1 in 10 events can be attributed to patients not taking their medication. So how do we improve adherence? This is another meta-analysis, but here they're looking at fixed ratio combinations versus patients who are taking free drug combinations. And as we can see with the forest line, across all 3 studies, 4 studies in this, most of it favors patients taking fixed drug combinations. Now, only patients who reported compliances were taken. So patients who say, I'm going to take my medication long-term, they had a wide variety of studies, including 2 for diabetes, 4 for hypertension, 1 for patients taking antiretroviral therapy, and 2 for tuberculosis. And this is quite a big meta-analysis of almost 12,000 patients. So the first thing we learned from here is single drug or single pill combinations are more likely to result in adherence to therapy. So drug treatment strategies should work on, for hypertension, 2 drug combinations. preferably within a single pill. We've seen this work in the HIV sector. Initially, we started with 3 different tablets on a stepwise progression. Then we started with triple therapy upfront. And now we actually have a single tablet with all 3 drugs in it. Is there evidence for using single pill combinations besides adherence? Well, again, here, poor adherence has been known in blood pressure as a major factor contributing to poor control. There's research showing that BP lowering pills, which are fixed combination or single pill combinations, have significant benefit over those that are individually packed. So here we're looking at 4 separate studies. The dark blue is your usual care, so individual drugs, and the lighter blue is single pill combination. And it does vary across the 4 studies, but in all 4, we see an improvement statistically of those patients who are actually on single pill as compared to free pills. Now, what about the combination of an ACE, a calcium channel blocker, and a statin? When we put these 3 together, do we get something like the Justice League, where we can actually go out there and look at multiple options to try and treat our patients better? What's the rationale for it? Now, the rationale for it comes from the ASCOT trial. While this trial is quite old, it's now almost 20 years old, it was 19,000 patients with hypertension between the ages of 40 and 80 with additional cardiovascular risk factors. And they were then randomized into a beta blocker with a diazide diuretic versus a calcium channel blocker with an ACE inhibitor. Then we had 10,000 patients who had total cholesterols who were randomized to take atorvastatin 10 milligrams or placebo. So we're basically looking here at multiple arms, atenolol and thiazide with and without a statin, and amlodipine and perindopril with and without a statin. If we look at the outcomes for the study from baseline, firstly, we see that if you take the combination of amlodipine and perindopril, so the calcium channel blocker with the ACE inhibitor, there's a 79% relative risk reduction in your cardiovascular risk scores. And if you add the statin to that, there's a further 53% risk reduction. Now, that's quite interesting, making this combination of amlodipine, perindopril, and atorvastatin very easy to decrease your patient's cardiovascular risk. Initially, just the blood pressure by 80%, and then by adding the statin by a further 50%. If we looked at that study, comparing atorvastatin, perindopril, and amlodipine versus the beta blocker and the diuretic, we can clearly see that the study favors the combination of the ACE with the calcium channel blocker and the statin therapy, whether it's for cardiovascular mortality, non-fatal MI, or total cardiovascular events. All of that was better in the group taking the atorvastatin, amlodipine, and perindopril as compared to the beta blocker group with the thiazide diuretic. We do have a follow-up study called the ASCOT Legacy study, and that's a 16-year follow-up study of the ASCOT initial trial. And that basically looked at what happened at the end of 16 years. And this was a sub-analysis of that data. And if we look at the slide, the graph on the left, 15 years, 16 years later, we see quite significant dissociation from the 2 curves, with the patients on therapy showing much better outcome in the long term as compared to those who were on just the atenolol and the thiazide diuretic. When you're looking at risk of cardiovascular death from statin, that's a 15% independent drop in it as compared with so 15% drop in the statin group as compared to the non-statin group, irrespective of which blood pressure tablet you were taking. So can you combine perindopril and amlodipine? Is there a good study that will tell us combining these 2 drugs has good outcomes? So we actually do have a study. This is called the Effectiveness of Fixed Dose Preparation Study, and where you compared, it was an open label, non-comparative study at about, say, 90 patients. They were all in the age group about 50 plus or minus 12 years with blood pressures at baseline of 160. And they basically looked at giving them combined therapy. And you see quite clearly, starting these patients on a combination pill, on the left-hand side, looking at systolic, on the right-hand side, diastolic. The systolic dropped from 160 within 3 months to about 127, which is within the guideline target. and the diastolic dropped from around 95 down to 77, which is also within the guideline target, clearly showing that you can combine an ACE inhibitor with a calcium channel blocker and have good outcomes. Now that we know about the blood pressure medication, the question is, which statin do we choose? Now, here's a meta-analysis of 164 short-term trials looking at statins, and I'm only putting up the 3 common ones that we use, and we can see quite nicely that 40 milligrams of atorvastatin is equivalent to 20 milligrams of rosuvastatin. So basically, when going from simvastatin to atorvastatin and then to rosuvastatin, the dose halves. So if we put it in a different way, 40 milligrams of atorvastatin is equal to 80 milligrams of simvastatin and 20 milligrams of rosuvastatin. Now, atorvastatin makes quite sense. We haven't gone into it, but there's lots of pleiotropic effects shown with atorvastatin. It is now out of patent, so there's a large number of generics in the market and very cost-effective to use. Another thing we have to talk about is 24-hour control. Unfortunately, a lot of the time, patients take medication where they do not have 24-hour control. So here we're looking right at the top of the first box, Perindopril. We see good control over a 24-hour period between 87 and 100% of patients. Amlodipine, and again, atorvastatin is designed to be dosed once a day. You can take it any time of the day. It is a statin which has the longest half-life. It's actually one of the more potent statins with rosuvastatin. So not only is these 3 drugs good in terms of doing what they're supposed to, they also lend itself to a daily dosing by ensuring good 24-hour control. Now, what about a fixed drug combination therapy, a single pill using all 3 drugs? So we have perindopril, amlodipine, and a statin combined versus patients who are not taking it or who are taking normal therapy. And quite clearly, we see here in the patients who are being treated, there's a marked reduction in their systolic and diastolic blood pressures over a period of time. There is also benefit beyond this. We have the effect on atherosclerosis. We know that atorvastatin modifies composite atherosclerotic plaques, decreases LDL, thereby decreasing inflammation and endothelial dysfunction. Over time, we have a decrease in your antioxidants and an improvement in endothelial function. Perindopril has an antihypertensive effect and has been shown in multiple studies to improve endothelial function and decrease cell apoptosis. Calcium channel blockers also have a good antihypertensive effect and antioxidant effect. So it actually makes sense to combine these 3 into a fixed drug combination therapy, which will then help simplify patients' treatment. It's a very busy slide, but it's just looking at fixed drug combinations with perindopril and amlodipine, or amlodipine and a statin, or perindopril with a statin, all of it showing multiple studies here. Fixed drug combinations of single pill therapies have better long-term outcomes in patients in terms of adherence, and more patients are likely to meet targets. Now let's talk about the beta blocker and the ACE. The beta blocker is like Deadpool. It's always had something there. People are always worried about beta blocker usage. The EuroAspire study was a cross-sectional study taken in 78 countries, 78 centers across 24 countries. Patients under the age of 80 with coronary artery disease who had either had bypass surgery or had a stent inserted or were known to be on treatment were identified from hospital records and included in the study. So we're looking at basically 16,000 patients, and about 24% were female. And the question is, what percentage of these patients are on different treatment options? And we see those with coronary artery disease, up to 86% of these patients were on a beta blocker, and with 65% were on an ACE inhibitor. So clearly we know that in this subgroup of patients with coronary artery disease, the use of a beta blocker is well established. If we look at going back here, patients with ambulatory blood pressures who were treated with ACEs, clearly this is just showing what we showed previously. Perindopril is a good drug. With all of them, all the statins across, all the ACE inhibitors across the board show reduction in blood pressure, but Perindopril shows the greatest reduction in aortic blood pressure as compared to any of the other ACE inhibitors on the market. The EUROPA study similarly showed an important point with perindopril alone, with a decreased primary endpoint of cardiovascular death, non-fatal MI or cardiac arrest, and myocardial infarction, both fatal and non-fatal. If we look combining these studies, so we're looking at three important studies, the ADVANCE, and the EUROPA, and the PROGRESS pool analysis. We're looking at a combined 29,000 patients with vascular disease, and the primary endpoint was composite cardiovascular mortality, non-fatal MI and stroke, and all of it shows benefit or favors the combination of a beta blocker with perindopril as compared to a beta blocker with placebo. Again, this highlights the importance of the ACE inhibitor as part of that combination therapy. Now we look at one of the beta blockers, and we look specifically at bisoprolol. This is a study looking, double-blinded study, placebo-controlled, looking at propranolol, atenolol, bisoprolol, and metoprolol. And across the board, we see that bisoprolol has good outcome in terms of reduction in heart rate, as well as normal cholesteremic hypertensive patient. It seems to have a good outcome. So it would make sense then to combine bisoprolol with perindopril. First, before we do that, we have to ask the question, what are indications for beta blocker use? Now, no, beta blocker is not for every patient, but in this group of patients where beta blockers should be part of your armamentarium for treating blood pressure, patients with angina, patients where you are requiring control of their heart rate, patients who are post-myocardial infarction, chronic heart failure with reduced ejection fraction, having taken into account the latest ESC guidelines, still has a role for beta blocker, and as I said, patients with atrial fibrillation. So while beta blockers are not for everyone, there is a distinct group of patients with these conditions as listed on the screen where beta blockers will play a role. Is there a rationale for combining the ACE with the beta blocker? Well, clearly we can see there is beta-1 receptor inhibition on one side, and the ACE results in a decrease in angiotensin II, as well as an increase in bradykinin. Combined, they improve blood pressure, as well as offer cardioprotection by decreasing your cardiac workload. So bisoprolol and perindopril make sense in combining it for multiple reasons. Number one, better adherence. Number two, better blood pressure reduction. And number three, better target blood pressure being reached. We have a study for this, and this is the fixed drug combination therapy of bisoprolol and perindopril, which was published 3 years ago. And it's a group of about 2,500 patients from 170 cardiologists who have hypertension, ischemic heart disease, and heart rates all above 60. And they were put onto this combination therapy for about 4 weeks and compared to see what happens. And clearly we can see from the dark blue to the light blue, a reduction in systolic blood pressure, as well as diastolic blood pressure, and a reduction in the heart rate to around 68, basically showing that this combination in a single pill works. So let's leave with some take-home messages and what have we learned from this talk. Well, atherosclerotic disease is a major contributor to morbidity and mortality worldwide and in South Africa. And over the last 15 to 20 years, it is coming higher on the list of what causes, or the number one cause of morbidity and mortality amongst our patients. Hypercholesterolemia occurs quite high. We're looking at 1 in 2 patients with hypertension having hypercholesterolemia. It's highly prevalent in our society or our country as a whole, and also highly prevalent within patients with hypertension. Together, they can increase your risk by double, depending exactly on how high the LDL is. Adherence is a major problem, and this is not only in the field of hypertension and dyslipidemia, diabetes, asthma, all our chronic conditions. Adherence is a real problem. The single pill combination of a statin with an ACE inhibitor and a calcium channel blocker has been shown to effectively improve adherence, as well as get to target blood pressure and significantly lower cholesterol. 30% of patients with coronary artery disease have an elevated heart rate. And in the study we showed earlier, having an elevated heart rate does increase your cardiovascular risk. In patients who require a beta blocker and ACE inhibitor, we now have a single pill combination. It's the only one of its kind, which is available to try and simplify your patient's treatment. When patients are on multiple drugs, simplifying pills and simplifying therapy is a convenient solution, number one, to reduce pill burden, and number two, to improve compliance. Shukran for your time, and we're available to take a few questions.
Jazakallah khair, Zaheer. I think the first question, Mohammed Timo, can you just try and clarify a little bit more in the chat box? You say with all any diuretic, I'm not sure what it is. Again, this says thanks for excellent talk. He's saying it's good to know that we've got to have a single drug combination, and he jokes and says eventually they'll add metformin to it, and then obviously it'll.
So it is coming. I can tell you in India there's a drug combination of metformin plus a statin plus indapamide. So they do have some single pill combinations in some other countries. Even within the field of diabetes, there's talk of a triple anti-glycemic drug coming very soon. So I think over time, we will start seeing more and more fixed drug combinations coming. The question then becomes just to choose the right one, which is appropriate for your patient.
If anybody wants to come on, unmute themselves and ask the question directly. Dr. Alikar, do you want to come on, or you want to just type your question in there? Okay, so Nadeem just wants to know, should he take the pills at night? Because some studies show that there's a benefit to take the pills at night.
So in the two single pill combination therapies which I showed earlier, they both actually have 24-hour level of control. So it doesn't matter when you take it. So whether you take it in the morning or at night, you're getting 24-hour control. Most of the studies did actually use it at night. My argument to patients is take it where you know you're going to be taking it on a regular basis. So if you know you're going to be taking it at Maghrib every day, and you spoke earlier about introducing the Sunnah, Maulana tells a patient, make your namaz 5 times a day, no one listens. But the doctor tells the patient, take your tablet after Fajr, the patient's going to get up for Fajr to take the tablet.
Yeah.
So, as long as they take it consistently every day.
Okay, perhaps some clarity on, do we have the drug available, and what's maybe the trade name of the drug and approximate costs here?
So both drugs will be available within a few months' time. They've both been registered in South Africa. The launch is fairly imminent for both of them. Servier is going to be the ones who will actually be marketing the drug. It comes in, just to answer Yusuf's question, it does come in different doses. So you have different doses of the statin, different doses of the ACE inhibitor, different doses of the calcium channel blocker. So you actually have quite a wide variety of doses to actually choose from.
And Zaid just highlights the fact that they say statins are better to be taken at night. I'm not sure if that got to do with the myalgia. And I mean, probably we can follow up that with the whole reduction in patients' heart rate in active patients. So, I mean, in active patients, should we be giving them beta blockers, and should we rather tell them to take the statins at night?
So statins are best taken at night. The reasoning for it is not 100% known. We do know that statins interfere with other therapies such as your altroxin, etc. So it's just got to make sure that drug-drug interactions don't occur. The myalgia is a very interesting one. If you go to the rest of the world, we do not see as much statin-associated myalgia syndrome as we do in South Africa. And I don't know really why. It's highest amongst the Indian patients, and even patients in India don't see that much high levels of statin-associated myalgia. So whether you're taking it at night, if you're going to get statin myalgia, it actually wakes patients up from their sleep. They will complain. They'll tell you, I've got a peripheral neuropathy. I had a patient who once told me, I have to wake up at 2, 3 in the morning. My legs are cramping. Another one who actually had to put their legs over the edge of the bed or make a wudu just to try and get rid of that burning sensation. So if you're getting statin-associated myalgia, you're going to get it regardless of what time of the day or you're going to be taking the statin. Okay. So it's not really to decrease the side effects. It just appears to be more convenient to be taken at night around the time of the meal.
Okay. I see Dr. Timor has clarified. He says, we're so used to having diuretics as part of these combos. Do we add a diuretic separately, or, I mean, do we offer the other combo with a diuretic?
So there's a study that's coming out very soon looking at what's probably the best what's the best option for therapy in our indigenous or our South African population. And they're looking at a whole lot of them. I think probably in a patient who doesn't have a compelling indication, there's still a role for a calcium channel blocker with a diuretic. And to answer the next question, probably indapamide is our better diuretic right now, especially in the diabetic population. But if the patient has compelling indications, for example, there's evidence of proteinuria, microalbuminuria, there's early eye disease, etc., then you're going to probably, or early heart disease, sorry, you're more likely to use a statin. I mean, ACE inhibitor over a diuretic.
Okay. Dr. Joseph is saying with amlodipine, how do you overcome the edema?
So it's with all calcium channel blockers. Licardipine seems to have the least amount of edema. It does show that when you start combining patients into fixed drug combinations, they actually have lower side effect profile as with the individual drugs. So there is studies looking at combining amlodipine with other drugs and side effect profiles. You tend to see slightly lower rates of edema as well as angioedema. Whether it's going to be in all patients, I don't know, but definitely all calcium channel blockers seem to have this non-selective calcium channel blockade of your venous blood system, which does result in edema. I don't know how to get around that in all patients. I think we've answered the question about thiazide. Please comment. Injectable lipid-lowering agents. There's definitely a role for the new agents. Okay, so right now, probably the way to go for lipid lowering is statin as first-line treatment and ezetimibe as second-line treatment, or in patients who are statin intolerant. In patients who actually are not getting to target with either statin or ezetimibe, we now have combination statin ezetimibe. We have a combination with simvastatin called Energy. We have a combination with atorvastatin called Lipids, and they both seem to work well. And indeed, the latest international atherosclerosis guidelines say in some patients, you might actually opt for dual statin therapy. The use of PCSK9 inhibitors, which is your injectable, that's for a reserved patient group. And I tend to use it in patients who are at very high cardiovascular risk, where we can't get the LDL anywhere close to target, or with patients who have FH. But I would suggest that we watch this space because there is an oral PCSK9 currently in development, and there's actually newer lipid therapies that are in development, once a year injectables or twice a year injectables. I mean, if you tell a patient, take one shot once a year, and that will sort your cholesterol out, I'm pretty sure people are going to flock that way. So just watch that space for lipid-lowering agents. There's definitely quite a lot of them coming in the market.
Okay. And I think, but with this, Yusuf and Dr. Hevaji asked similar questions to do with HDL. They talk about women having generally a higher HDL level. So obviously your targets for treating, and it will be a bit different. They want to say between the genders. And Yusuf wants to know what is the best way to increase HDL.
So from Farouk's question there, a patient with an HDL of 1.8 and an LDL of 2.8, total cholesterol of 6. I think you'd have to work out a Framingham score. Just off the top of my head, that risk, if they're not hypertensive, if they're not smoking, should be around 4%. So if you have a Framingham score which is high, then absolutely I would consider treating that patient. Remember, your target LDL in a male is 1.0. and above 1.0, in a female is above 1.2. There are other things that you can look at. You can look at your risk combination, or so what's your risk of good cholesterol, or your ratio, sorry, of good cholesterol to bad cholesterol. I would urge you just to download the app. It's called MedCalc, or you get Fram. The ESC, the European Society for Cardiology, have their own app as well. But I find the MedCalc one very easy to use. You punch the numbers in, it will give you a percentage risk over 10 years. If it's under 5%, for primary prevention, there's no real benefit. Between 5 and 10, it becomes a discussion with your patient. And if it's above a 10-year risk, you will always treat that patient. Okay. In terms of how do you raise HDL, the best way to raise HDL is genetics. If you don't have good genetics, there's not much we can do. But it has been shown good exercise, increasing food intake that has healthy cholesterol, such as your unsalted nuts, your olives, etc., will raise healthy cholesterol. There are one or two molecules that are currently being looked at to raise HDL artificially, but the answer here is hard work, exercise, and good diet. That's the only way now that we know of successfully to raise HDL.
Okay, Dr. Joseph, I just wanted some clarity on the L-troxin statin drug interactions.
So you can't take your altroxin with your statin together. They need to be at least 3 to 5 hours apart. So your levothyroxine does interfere with statins, and the statins decrease absorption of levothyroxine. So we recommend that patients actually take levothyroxine first thing in the morning and take the statins at night.
Okay, and then Nadeem, just wanted to know if is there a ARB statin combination?
There is one that's being looked at, but as far as I know, it's not coming to the South African market anytime soon.
Any other questions for Dr. Bhayat? Very fantastic. I'll take the silence as a sign that we've covered all the topics. Once again, Jazakallah khair, Dr. Bhayat, for an entertaining, very enlightening talk. It's exciting with such a large burden of disease and poor patient compliance. I think that's the biggest issue and the worry on most of the healthcare workers' minds. Dr. Magda, I just wants to know, how often should you check for microalbuminuria? I'm going to assume.
Yeah, so in a patient with diabetes, you should screen them for microalbuminuria once a year. If the patient does have microalbuminuria and you are treating them, then depending how often you see them, either 4 or 6 monthly, at every visit, you should keep checking until it actually goes away. Okay.
And then Dr. Hafiz just makes a comment that he says that in personal experience, a tablespoon of olive oil on an empty stomach has raised his cholesterol by 0.3. Well done, Dr. Hafiz.
Alhamdulillah.
Okay, so I think we still got a couple of more minutes for questions if anybody wants to come on. Otherwise, we can close the meeting. While I have everybody on the line, I'd just like to encourage you to join the Islamic Medical Association of South Africa if you're not a member. You know, this is the advertising spot while you guys are thinking of more questions. I've flighted the poster of our bursary scheme just before the meeting started. We're running a healthcare worker bursary scheme nationwide, preferably in the health sciences. It's across all spectrums, not only open to Muslim students. And so far, we've got 6 patients on. We take Lila and Zakah. And I think it's a worthwhile course to get involved in. Dr. Desai wants to know, how do we treat the ACE inhibitor cough, Zaheer?
So patients who develop a ACE inhibitor cough, it's a bradykinin response. You got to stop the ACE inhibitor and then move across to a ARB.
Yeah, all right. So I think that's it. I think we can close the meeting now. I'd just like to thank Dr. Bhayat once again for giving us his time. I'd like to thank Zaheer for sponsoring it, and I'd like to thank all of you for taking out your Wednesday evening to spend some time with us. We make dua Allah accept all the efforts of everybody, and we will close with Al-Asr. أعوذ بالله من الشيطان الرجيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.